Yeah, guys, so we deal with a lot of patients who are dealing with cardiogenic shock, and we use medications called inodilators. Inodilators, just like the name describes, are medications that both provide inotropic support, meaning they increase contractility, as well as help dilate blood vessels. Patients who are in cardiogenic shock usually have decreased contractility, and usually the body's response to that is to increase their systemic vascular resistance, or SVR, and it makes it even harder for the heart to pump against an increased SVR. So in theory, having an inodilator helps your contractility and reduces SVR, making it easier for the heart to contract against the dilated blood vessels. Two medications we commonly use are dobutamine and milrinone. Dobutamine is a beta 1 and beta 2 agonist. The beta 1 properties are what increase contractility, and the beta 2 is what causes a vasodilation. Milrinone is what we call a phosphodiesterase 3 inhibitor, which increases cyclic AMP. And increase in cyclic AMP can have multiple different physiologic effects that happen. But in this case, it increases contractility as well as vasodilation. These medications are particularly useful in right ventricular heart failure because a lot of times the right ventricle has a very difficult time pumping against an increased afterload. So patients who have pulmonary hypertension will get a lot of benefit from these inodilators. Now, when picking or deciding which one you want to use, there is a New England Journal of Medicine article that compared both of these medications to each other in cardiogenic shock patients, and they found no difference in terms of in-hospital mortality, morbidity, initiation of renal replacement therapy, initiation of mechanical circulatory support between the two groups. And so there's really no difference, and a lot of it comes down to your hospital practice. Another way you can accomplish a similar result is by using epinephrine for your contractility support, and then using inhaled pulmonary vasodilators like inhaled nitric oxide or epoprostenol. In addition to adding contractility and vasodilation, the adjunct treatment to heart failure is going to be diuresis, so that you remove a lot of the volume that's in the heart, which allows the ventricles to then squeeze better, and then you're able to wean your inotropic support. Few times that I try not to use inodilators and tend to use more epinephrine is when I have patients who have septic shock from either pneumonia or bacteremia. And septic shock can drop your SVR. And so already having low SVR usually isn't an ideal situation to use inodilators. In these patients, you may end up supporting their blood pressure with vasopressin or levophed, and then end up using epinephrine as your contractility agent. Anytime we're using medications like this, it's always important to track the cardiac output, whether you're using the PIC principle or a cardiac output monitor on the PA catheter. And this is what's going to help you guide your management in terms of titrating down your inotropic support.